Good evening. I'm David Levine. I'm co-chair of Science Writers in New York. Behind the camera is the other co-chair of our group, Joe Bonner, who's recording this, producing it, and we'll be putting it on YouTube as always. My guest tonight is Dr. Mark Mulligan. He's a Thomas S. Murphy Professor in the Department of Medicine and Professor in the Department of Microbiology at New York University Grossman School of Medicine. And he's Director of the Division of Infectious Diseases and Immunology at NYU Langone Health. He investigates the innate and adaptive immune responses to pathogens and vaccines by studying how the human body successfully reacts to vaccines and battles infections, and how infectious pathogens escape immune surveillance. On March 11, 2020, the NYU Langone Vaccine Center enrolled the first patient infected with SARS-CoV-2, which we know as COVID-19, into an investigator-led study protocol. So welcome, thank you for doing this. I know you're a busy man. So, today or yesterday, Janet Woodcock told that we're all going to get it. Dr. Fauci now says we're probably all going to get it as well. It's been shattering records. The CDC says that the Omicron variant is responsible for more than 98% of the COVID-19 cases in the US, replacing Delta in less than a month. So it's very efficient. And an average of more than 761,000 Americans a day tested positive for COVID-19 on Tuesday, the day of the hearing. So talk to us about this variant. It was announced the day after Thanksgiving. Everyone was kind of hopeful. Broadway reopened. People were going to museums, people were eating outdoors, and now all that's in question.
Yeah, thanks, David. And thanks to you and Joe for the invitation. It's a real pleasure to be here, and hello to everybody in the audience. Omicron certainly changed everything very rapidly. Early November, it was starting to spread and got on the radar in South Africa. Thanksgiving, the reports came out, and it sure changed the holidays in the US. And really, we've just entirely switched over now from Delta to Omicron. And when it first came out, David, there were three questions that were on my mind most of all. How contagious is it? How serious is the disease? And will the vaccines protect? And we actually know the answers to all three of those questions now, just about a month later. I think our first US case was early December. So we know it's highly contagious. It's probably several times more contagious than Delta, which was much more contagious than Alpha, the UK variant that came before Delta. It is less severe. Probably everything that was sort of suggested by the early South African experiences seems to be coming true. So it was a pretty good barometer. One, it would seem more contagious. Two, less severe, and it is. I think that's pretty clear now from a number of different studies around the globe, and including countries more like the US, like Israel, UK. And then three, in terms of vaccines susceptible, will the vaccines protect? The answer is yes, they protect against severe disease. That's their main job. We've sort of changed that expectation a little bit over time, I think, but it is true. And they're highly protective against severe disease. However, the virus is not as susceptible to vaccine-induced antibodies. And we're seeing lower levels of protection against either asymptomatic or mild to moderate disease. So the good news is, if you're vaccinated, boosted, you're gonna do well. I think if you're unvaccinated, or even those vaccinated but maybe older or with compromised immune systems, there's still some concern. And the other thing I wanted to say, and I'll stop in a second because I don't want to talk too long right now, but is that as we as we headed into this, it's so different than where we were in 2020. We have home testing, masks, very clear, the masks should be worn. We have vaccines for kids down to age 5. We have boosters. We've got monoclonals for outpatient treatment of those with risk of progression to severe disease. We also have a monoclonal for prevention now for those who cannot respond. I have a patient who got 4 shots. She's got cancer treatment, one of our nurses, and she just made no antibody after even 4 shots. She's so happy now because she got a dose of a monoclonal that was recently approved for prevention. It will provide 3 to 6 months of protection for her.
Is that elbow shield?
Yes. And then we have oral drugs. They're still kind of coming into focus. They're over the horizon. They're within reach. But boy, you better be quick once the supply comes in, because it goes quickly from the limited pharmacies and kind of comes in once a week and it disappears in a few days. So then it's not available for a few days till the next. So there's a high demand. And so figuring out how to use these. We have inpatient treatment protocols and drugs, so much better than 2020. Back then we were learning, sort of, as they say, building the ship as we or building the aircraft as we flew it. Well, now, the aircraft's built and it's pretty good. Of course, we would like some things to be better. And then last thing I'll say, we're now 2/3 vaccinated nationally. It's not enough for herd immunity, and the variants change and put a little spin into that, but back in 2020, we didn't have any vaccines. We had no population immunity, and now 2/3 of us have something. So that's fantastic. So very different than where we were in 2020, and I think overall we're going to do better with this thing.
So the headlines tonight are that in some eastern cities, the rise is slowing down, like in New York City and some others, but it's still very high. And I know a lot of people who are testing positive. And if you can get a test, I took a test somewhere and I never got the result. They're just so backed up. And I said, well, it's 10 days. I mean, anyway, but it's, home tests are not that easy to find either.
No.
At the moment. So, I want to ask you, so why don't you tell us, so Evusheld is news. It's the FDA authorized a new long-acting monoclonal antibodies for pre-exposure prevention of COVID-19. So what is this drug?
Yeah. Monoclonal antibody, it is given as an intramuscular injection, basically 2 shots, that's split into 2. And so you get a shot probably in the gluteus, I imagine is where they're giving it. And a monoclonal antibody is something that has come from, but is made in laboratory, is safe, sterile. And basically, this is what we call passive immunization, would be the technical term, for people who cannot make a protective response to active immunization, vaccination. We can give them the end result, which is, or at least part of the end result, antibodies. We're not giving them T cells. So it's a drug, made in a facility and tested in clinical trials. And this thing is shown to be about 80% protective, to reduce over time, to reduce infection in individuals who can't otherwise mount a protective response. So for that nurse I identified, who has just been, very anxious and, wanting to have her wedding and wanting to be able to work her normal job in the hospital, she hasn't been able to do a lot of those things. Now, I think she might have a greater degree of comfort for at least some of these things. So it's really an advance, I think. And this one, it was approved just like the one monoclonal that we think still has at least some activity against Omicron. the one other for treatment of outpatient mild to moderate disease and those with risk of progression, there's one that still probably has activity. That's sotrovimab. This one, Evusheld, similarly, it's significantly reduced, but probably still has some activity. They were studied and approved based on Delta. Then Omicron came along, and we don't have the data, but in clinical trials, in terms of an in vivo effect, but the laboratory data, although they may be down significantly in terms of neutralizing Omicron relative to the Delta or the original strain, still, we get such high levels of drug in the body with these monoclonals that they probably still are going to provide a level of protection, to be determined. But those two will, I think, will be used. And the other monoclonals, Lilly, Regeneron, they're out. They're going to have to come up with something new. What we really need, David, is what we call a BNAB, a broadly neutralizing antibody. I had a conversation with Regeneron this week and asked them, what we need is a monoclonal that would be active against both Delta and Omicron. And, I think all of the companies are working on those. The way they develop these is they study people who've successfully fought off and recovered from SARS-CoV-2 infection. They take their B cells, they do some cloning of the antibody genes, and then they screen them in a lab to find out which antibodies have the highest, strongest activity. Then they mass produce them using, pretty modern techniques and convert them into a drug that can be either infused in the case of sotrovimab or injected in the case of Evusheld.
All right, so I had a lot of questions. I usually don't have so many, but a lot of people sent in questions in advance. And for those listening, if you have a question, please put them in the Q&A box, not the chat box, the Q&A box, and I'll get to those. So the first one is, why is Omicron so much more contagious than other variants?
Yeah, the very first thing we heard about this was it's highly mutated in the spike. So the virus has 10 or 12 genes. The spike is the protein on the surface of the virus that attaches to the ACE2 receptor in the respiratory epithelial tree. And the virus has many, many more mutations than even Delta had relative to the original strain. Something like 30 or 40 mutations in the spike protein. And many of these are in areas of the receptor binding domain, the RBD of the spike protein, the part that actually is in physical contact with the virus receptor on pulmonary epithelial cells. And the thought is that this is binding very tightly. It really does a good job of attaching to the receptor. That's one efficiency of binding through mutations in the receptor binding domain. If it can attach to the thing it needs, sort of like putting a key in a lock, if the key can really slip into that lock and stay in there good, then the virus can get into the cells and infect. The other is that there seems to be a pretty high level of virus, in the throat, and relative to some of the earlier strains, some reports of that. And it may be that this is leading to, more virus going out with coughs, droplets spreading. Those are really the best things I could say at this point. It has mutated in the spike significantly, and it's made it much more contagious than what we previously were calling the very contagious Delta variant.
So this is the very, very contagious.
Very, very, yes. We're going to run out of varies if this keeps going.
Okay. So as you know, Pfizer said they're going to have a new vaccine ready in mid-March. Does that mean they'll have to apply for authorization, experimental use authorization?
Yes.
Okay. And it may be a while before it's ready. So that leads me to a couple of questions. Several countries are giving fourth booster shots. I had my booster shot in August. Should I be thinking about getting a booster shot? Not that I really can yet, but
Yeah.
do you think that's going to be coming?
I think I think it's more of a matter of when maybe than if, but most likely, and it could be a year, David, it could be sooner. So third dose boosters, you've noticed we've compressed a bit now, 5 months.
I know, yeah.
And I think we might even shorten that more to try to get people protected, because what's happening, the Omicron does have some resistance to the vaccine induced antibodies, again, because of those spike mutations. And so when we have waning of antibody, which is normal, it's what the immune system does, it sort of goes, simmers down, and the antibody levels go down over weeks and months. It falls below a threshold that provides, the level of protection that maybe we would desire. So you give a booster and you bring it back up, but again, it will drift down. So your question is, well, how long until it drifts down where we'll need a fourth booster? And we don't know the answer. Nobody knows right now. Israel has implemented for ages 60 and over, and they do have data that if you give a fourth dose, it does knock the antibody up about 3 to 5 fold higher. So that's good. And that's not that surprising. They're beginning to put some data together on whether that fourth dose makes a difference already relative to people with just 3 doses. And perhaps it will. The hope here, I think, is that, first things first, let's get everybody vaccinated primary series. Second thing, let's get everybody their third dose. But here in New York, we've got an awful lot of people vaccinated and an awful lot of people boosted, third dose boosted. So that does come up, and I get asked that fairly often. We're not there yet. It's not yet policy in the US. It is in UK. I think we're going to be studying it. So I would say stay tuned, and that for now, you're okay and others are okay who've had their boosters. I do want to say another word than just the yes answer I gave you. My shortest answer so far, my one-word answer to your question. Will they have to seek EUA for a Omicron specific variant vaccine? Both Pfizer and Moderna are developing these. Pfizer seems to be a little ahead. Yes, they say they're going into trials. In fact, they may have started. We're going to be participating at my research clinic at NYU starting next month on an older age group. They're starting in a younger age group. So we're looking forward to having a variant specific vaccine. The other variant specific vaccines that have been used so far, David, didn't really make that big a difference for Delta, Beta, relative to the original strain that we're currently using. And so we're okay with the original strain for those earlier variants. This one is so highly mutated that it could be that a variant specific vaccine would be, quantitatively, qualitatively better. We don't know that yet, but I think it should be investigated, and that's what the companies will be doing. And if they did have, a set of data to present in terms of initial safety and antibody responses in a medium-sized group of individuals, maybe a few hundred, present that to FDA in March. It would take a few weeks for review, and we'd be a little further into spring probably, if that did seem like it would be very important to roll out. So I wouldn't count on it. And we have first business to attend to getting everybody their third dose or their first 2 doses.
The other thing, people said to me, says, well, since this variant came very quickly and is leaving very quickly, by March or April, it might be gone. So what's the point of getting that vaccine?
Yeah, it's a great question. A few things. One, you might get it before it's gone, and it would protect you against severe disease. So I'm glad you got it. 2, this is not the last variant. I don't have a crystal ball, but if you look at 2021, we started the year with Alpha, the UK, then we got the Delta. It came from India, and now we have Omicron. So we had 3 variants dominating in 1 year. I think we're going to have a couple more variants in 22. So getting a booster is a good thing to be ready for the next thing and to get us through this, this current wave. The other thing is the waves in the Northeast, as he suggested, may be peaking soon and then starting down. Data out of South Africa and a few other places, UK, suggests they peaked pretty quickly and started coming down. However, there are other places where this wave may be lagging, starting a bit later. And if you traveled, or if someone traveled to you from those areas, they might, you might be exposed. So I just think it's a good thing to do.
So if you had a choice between a 4th booster of the regular, vaccines, or should you be waiting for the
Oh, yeah, Omicron. Don't wait. Get it now, because
but you can't get it now, right? No.
oh, I'm sorry. Yeah, you said 4th dose.
Yeah.
So you're saying when it becomes available, if you could get a 4th dose of the currently available, or Omicron, what should you do? Is that what you're asking?
Well, let's say you can get the 4th dose next month. I mean, should you hold off because the other one is coming?
Oh, yeah, no, no,
Okay.
bird in the hand's worth 2 in the bush, and this disease, this virus can be very serious
Okay.
for those with risk factors, especially. So no, I don't think I would do that.
So in Israel, they're waiting, I think, 5 months between the 3rd and 4th dose.
I believe that's where they are. Yeah,
Okay.
I believe so.
So another question, someone says, which vaccine series gives the best COVID coverage now? 3 Pfizer doses, 2 Moderna doses, followed by half a dose Moderna booster, or 3 full Moderna shots?
Yeah, we did participate. I mean, those are all homologous prime boost, meaning same vaccine, except for the one with the half dose. It's same vaccine, Moderna, but half dose, which is what's authorized. So you really can't, well, you'd have to do a little bit of trickery to get a full dose Moderna as a booster, but what's authorized is the half dose. So let me just put that aside, and let's just say 3 Pfizers or 2 full dose Modernas, and then the available booster Moderna. Flip a coin. We did a study that's coming out in New England Journal. It's embargoed right now. There's a press release from NIH that I reviewed yesterday. And this is the mix and match study. There's a preprint out already. It's already had plenty of press. And this is the data set that led to FDA and later CDC authorizing and recommending boosters with any vaccine following any prime. The only one perhaps to steer from might be the J&J boost after a J&J prime, just because of the levels there of antibody. This is not taking into account T cells. Antibody were significantly lower. But for Pfizer, Moderna, with a booster, they're pretty much flip a coin. So I think some of the early data suggested, in newspapers and even some reports that, well, maybe there's some advantage to Moderna, but they used a very high dose for their primary series, and they realized that, and they brought it down now for their boost. So,
okay.
Flip a coin.
So if someone says, I had a Johnson & Johnson vaccine, then had a Pfizer booster in early November. Should I consider getting a second Pfizer/Moderna vaccine?
Sure, when it's available. It's not available right now. I mean, if you have a single RNA, so remember the J&J, well, let me back up. Yeah, what's recommended for people with a J&J primary is to get a booster with any of them, and you've done that. This person's done that. So yeah, really they have taken care of things. But actually the recommendation is if you had a J&J prime, within 2 months to get a second J&J, and then that's considered the prime. And then after, it would now be 5 months, I think, you could get a Pfizer. So really that person sort of skipped the second, but that's probably what I would have done too. I would have gone right from J&J to an RNA. And I think you're fine. The J&J primes really well for RNA boost. In our New England Journal paper that's coming out later this month, and there's a preprint out already, you can see those data and look at the antibody levels. And a J&J prime followed by either Pfizer or Moderna boost gives you levels of antibody that are essentially equivalent to straight RNA, two RNAs followed by one RNA. So I think you're good, and just stay tuned for the fourth dose recommendations that will apply to us all, but no need to do more right now.
Okay, so I gotta take this from a family member. Should I take an antibody test before getting the fourth dose? I had the third dose the end of August. And I guess John Moore said that the FDA does not recommend antibody tests to see how well the vaccine's working, only to see if you had COVID.
John spoke the truth, and I don't recommend it either.
Okay.
These commercial antibody assays are semi-quantitative or qualitative. There's some confusion because some of them don't even measure what's in the vaccine. They measure the N nucleocapsid protein, which will tell you, as you said, David, that you've been infected. So it's not recommended. They're not intended to give us any gauge on our level of protection from vaccines. So my answer to that family member is no, don't. You don't need to do that. If you're in a category that needs a boost, it's due for a boost, get the boost. One thing I want to point out is that many people have not yet quite internalized is that for severely immunocompromised individuals, CDC now recommends 3 doses as the primary series. You get of RNA, for example, you get the first 2, and then I think it's a month later you can get another one, so that's 3, because they don't respond well. These would be like transplant patients, cancer, highly immunosuppressed, serious immunocompromised. And then after 5 months, they can get their booster. So that's the one group that has a quote authorized pathway to get 4 doses right now in the US.
I have a friend who has lymphoma. He's gotten 3 shots, and they measured him with, very sophisticated. He has no antibodies.
Yeah,
so he's trying to get on the trial.
Yeah, well, trials are always good. I'm a trialist. But he could get, if he had 3, he can get a 4th 5 months after it's authorized,
Right.
and he can think about Evusheld.
Okay. Can anybody? So he can get that? That's because that's approved, right?
It's approved for seriously compromised individuals who don't, like at NYU, we're putting in a criterion, or at least thinking about it. I think it's there now, but still thinking some that I'm kind of going the other direction on the antibody test, that you have to have an antibody test that shows no antibody. Basically, like him, they've had 3 and they don't get any antibody. And before we provide this extremely limited, very valuable resource, we want to give it to those who most need it. All of these things, the monoclonals that we've talked about, the oral medications that we haven't talked about yet, tightly limited supply now, but that'll get better.
Okay. So it's a lot of different questions. So let's the elephant in the room. How well do you think the CDC has done in communicating to the U.S. public about the pandemic?
Yeah, I think they've done pretty well. Come on, no one's perfect. We have a new director. I think she's done a pretty good job, and they're not perfect. They're human like the rest of us. They are, in a position of great responsibility, a hot seat. I think that, some of the criticisms probably relate to some of the unfortunate infusion of politics into science and medicine. They are charged with protecting and restoring human health from medical threats, particularly infectious diseases, communicable diseases. It's in their title, but they also do chronic diseases like diabetes, hypertension. But they're in a tough spot. Think about it. The vaccines, when they first rolled out, tremendous criticism of the rollout process. You couldn't get them, you couldn't find them. The phone people were calling phones all night long to try to get an appointment. And then now we got more vaccines than people want to take. So it's going to get better in terms of, test availability, which is the hot thing now, and even the drugs and monoclonals. When you roll out anything, there are going to be some bumps in the road. I tend to be understanding of where they've been, and I think they have excellent scientists. I think Dr. Fauci works very closely with them, and I respect him and think he's done a really great job. So, I would give them a pretty good grade, and not perfect. Sure, we can all do better, but I don't think any of us on the call have gotten everything right first time all the time.
No, that would make me doubt doubt people. You get it first. So let's talk about the testing. Someone asked, I've read that the at-home tests have so many false negatives. If so, what's the point of using them?
Yeah.
I mean, first of all, is that true?
Yeah. No. Well, that's a qualitative statement. They do have more than the PCR. So the PCR is a test that amplifies and measures viral RNA. So it's very sensitive. The antigen test measures the viral protein, and not as able to pick up smaller amounts of virus. So there will be a day or two at the beginning and a day or two at the end where you might still measure by PCR, but you won't by the home antigen test. However, the antigen test has a definite role. It is worth doing, particularly in somebody with symptoms and somebody, at the, sort of at a time when their symptoms are becoming more and more significant. So, or even early on, I think it is worth doing. Very early, very late, it may not, it may not pick up. If it's negative, it's probably worth repeating if the symptoms are progressing and they're sort of typical. So I think it's a good additional tool. It's not the same as PCR. It doesn't measure quite as much as PCR, but I think it's worth doing. Yeah, I do it, whether for symptoms or for, like when was it? New Year's, when the grandkids were coming over, my wife and I took tests, and they all took tests, and we were all negative, and it helped us feel, okay, this is reasonable to gather. And I think a lot of that happened around the December, January holidays.
So so what is the incubation period for Omicron? I'm trying to figure out how I got it, because I'm very careful and wear a mask consistently. I tested positive with the antigen December 28th, with a cough that started December 26th. So are the surgical masks useful? Does having had Omicron provide much immunity? A lot of questions in there.
That's a lot. There are several there. I mean, if I won't remember them all, and you can help me, but
you can read in the chat if you want.
Yeah.
Okay. I'll remind you.
Yeah. First of all, you're not alone. So many, as David said at the top, so many people are getting it, and you shouldn't feel that you did something wrong. This thing's so contagious. I don't disagree very much. In fact, I've been saying something similar, that it's likely that most of us will get this, even vaccinated, and we'll be okay. It'll be mild, moderate at worst. But how we get it, it could be that this thing's so much more contagious that it's more floating in the air more. Measles, I'll say, is so contagious that we say the room is contagious for 2 hours after someone leaves. And because that virus floats in the air, and TB does that, and we have chicken pox can do that, varicella. Flu is not. Flu is droplets, and that's why 6 feet, and that's kind of been the standard for Omicron, that it's probably mostly droplets, 6 feet, social distancing is adequate. I do have to wonder if is there something about this now that it's so contagious, maybe it's floating in the air a little better or more. And next part of the question, masks. Yes, surgical masks are worth doing. You could consider an upgrade to one of what are called the sort of higher density masks, KN95. There's a K something 94, and then I wear an N95. I'm at work, I'm getting exposed to patients and research subjects, doing illness visits for people that I know have COVID in the hospital or in the clinic. And I wear K95, I wear eye protection, et cetera. I also ride the train in from New Jersey if I'm not staying overnight in the city. And I wear my N95 on the train as well for Omicron. I didn't before. I was wearing surgical for Delta. So I think there's some upgrading of masks going on. And if you can get the, there's a whole thing about ordering these maybe, through good sellers. If you're going to try to get the N95 or KN95, it could be worth considering. Okay, another part of the question was, what about prior infection? Yeah, it provides some protection. I mean, in a way, it's like vaccination. Your body's immune system is being exposed to this foreign invader and saying, this is bad, I need to mount a defense, and it does, and that's what it does to vaccines. But vaccines are a safe way to get immunity. Infection could kill you, before you mount an immunity if you're naive, haven't been vaccinated. So we prefer to make people immune through vaccination, but having infection does provide a level of protection, and it frankly not probably as good as these vaccines, these RNA vaccines. They're so good, but I think it will provide a level of protection. But still, everyone who's been infected should get vaccinated. That's the recommendation. And you actually have a very strong response to the vaccine after infection. Wait about a month because you've primed the immune system. It's like getting a first dose of vaccine for free, but although you had to be sick to get it, and now you get your booster with the initial vaccine in a way. So yeah, it's a good thing to do. What did I miss? There might be one more.
No, I think that's it. I want to go.
All right.
So someone said, okay, so you're wearing eye protection. Should
Eye
we?
protection when I see patients. That's a standard in the hospital.
Okay, but you don't need to do it outside.
No, I don't. You remember we've all seen people in the streets with face shields and gloves, and
Right.
I think we've moved away from that a little. It's better to wear the nose and mouth cover. You need to cover both with the mask, and we're less concerned, I think, about fomites, which would be transmission on hands and so forth, than initially. Although I still think hand washing is important, and I'm back to elbow bumping. I had probably as Delta was kind of waning in New York, I was getting back to handshaking, but now I'm back to elbow bumping. So I don't think face shields, eye protection are needed for outside medical. No.
Okay. So we have a listener from Australia saying, who is doing the vaccinations in the US? In Australia, we have vaccination centers with nurses getting vaccinations plus GPs, and pharmacists across the country are being paid a fee to give the vaccinations as boosters after 4 months here. So, I mean, I got my vaccine at a pharmacy. I think most people are getting them.
Yeah, and that's the way it needs to be. We need to make it as easy as possible, remove all barriers, and so mobile vans. So, the answer is basically all the same things you're doing there. We don't have 4 months, we have 5 months is our time now for boosters. It was 6 months. It may be shortened more is my feeling, given the emergency that we're in with this. I think they're reviewing all available data to see if that would be reasonable in terms of safety, immune response. I think it would be probably. I applaud what they're doing in Australia. It sounds right. And I would take it even farther that, the mobile vans, the pop-up schools, school nurse, making it easy somehow, with parental permissions to do it there. So nurses, physicians, pharmacists, you do have to, I'm pretty sure probably in New York, you have to have be a sort of a clinician in order to administer a vaccine, either pharmacist, nurse, doctor, although I might not be right. I've been in New York a little over 3 years, but I'm sure that's probably the case. So wouldn't be just somebody who was like a technician, probably, who wasn't medically trained, but we need to make it as easy as we can. The ideal vaccine, this is my dream, would be one that we could mail out to every household and you just vaccinate yourself. And I've worked on such a vaccine. There are these, we published in Lancet with flu, a novel microneedle patch vaccine that just, you slap it on your skin, leave it for 5 minutes, and you're vaccinated. It has these little needles that go into the skin, really, the dermis, and stay in there, but they dissolve. They're the same material as like dissolving sutures that can be left in after you get a cut in an inner layer. And this is the kind of future technology we'd like to have. Imagine if we could vaccinate the whole city within a week or two by those who would do it, mailing to every household. You know, if you got 4 people in the house, mail them 4 vaccines. That's heat stable, doesn't need a freezer. We need to be moving that direction. Some of the older technologies with less freezer refrigerator requirements than the RNA, for example, probably to get the whole planet vaccinated, which is what we need to really control this. We're not talking about eradicating or ending, it's control. We need to get most of the world immune through vaccination. We're going to need some old, simple technologies, and these have to be developed more.
I know I was speaking to a doctor in Kenya, and he said 4% of his country is vaccinated. And in South Africa, it's 7%. But he said, we know how to handle it. We were used to Ebola. We're used to all these other things. So one question is, how concerned should we be about the new variants developing in poor countries where very few people are vaccinated?
Yeah, or in Alabama or Georgia, where very few people are vaccinated. I think, yeah, we don't have to point the finger too far, but, and I'm kind of joking, but I get the point, and I think we should be concerned, absolutely. In fact, in thinking about things I might want to say, I would say my greatest concern is, I used to say this during Delta, my greatest concern is not Delta, but what might come next. Well, now we have Omicron, and in 2 of the 3 ways that I talked about at the beginning, it is worse. It's more contagious. It's less susceptible to vaccination, although vaccines still doing their job for serious disease. However, we got lucky in that it's less severe disease with Omicron. What I fear most, what I am concerned about is, and we will have additional variants because we don't have the planet mostly immune yet. Maybe we'll get 2 more this year in 2022. Let's see what they're going to be. We had Alpha, Delta, Omicron. We're going to go through the Greek alphabet. My big concern is that whatever's next or some other future will be a real killer, one that would cause a lot more death and mortality, that had mutated in some way to make it more highly pathogenic. That is what I'm concerned about.
Okay. So someone asked, do you see a universal vaccine coming?
I've got a new postdoc coming to my lab to work on that. We need one for flu, and we're going to work on both. We need one for SARS-CoV-2. This is the 3rd highly pathogenic beta coronavirus. We had SARS-1, then we had MERS, and now we have SARS-2. SARS-1 had 10% mortality. MERS has 30% mortality. We're lucky that, the SARS-CoV-2, the mortality is, 1 or 2% or less. And so since we've had 3 of these now, in 1 every decade, so 3 in 20 years, these coronaviruses, yes, we do need a universal coronavirus. We also need a universal flu vaccine. And I think these are achievable, but they're lofty, sort of aspirational, ambitious goals at this point. The focus would have to be on a conserved part of the virus, or picking a part of, which would not be the spike, which mutates a lot. So some of the, excuse me, some of the other proteins in the virus, like, sorry, try this. That's not a beer, that's a LaCroix water. So, for example, nucleocapsid is a great T cell target in the coronaviruses, and with natural infection, we don't get that in the vaccine. It's the dominant target of T cell responses with natural infection. So things like that, non-spike proteins, non-surface proteins for flu virus or coronavirus is one of the ways to approach these universal. So this is a goal. Before SARS-CoV-2 came, Dr. Fauci was very keen on an initiative at NIH for a universal influenza vaccine. I thought that's what I'd be working on in these first 3 years at NYU. That was my plan. Obviously, we have another virus, and we're doing the immediate things, but also we're want to be working on a universal vaccine. What that means is one that would protect against all current variants, future variants. It would be durable, long-lasting protection, and would provide a high level. Those are the three things you want in a universal vaccine: protection against multiple variants, so breadth of protection, durability of protection. We don't want to have to give a shot every year like we do for flu. We may have to do that for a while for corona. Right now, we're every 6 months. And then high level protection. Flu shots are, in good years, 50, 60% protective, quite a bit lower in bad years. We still need to take them, but they need to be better. So, and we are seeing flu this year. It's different. We have patients every day at NYU getting diagnosed with flu now. We had none, essentially, last year. So after almost 2 years now of no flu, we're starting to see it this year. So stay tuned on that part of the story this year.
Okay. So I just want to clear up, some question. So you said that measles can stay. I know I got an email from the Metropolitan Museum 3 years ago that said somebody had measles, just letting you know. And I said, well, I had measles. I wasn't that concerned. But he said measles can stay in the air 2 hours. So how long can this variant stay in the air?
Yeah. So the thinking is that SARS-CoV-2 is spread through droplets and it doesn't stay in the air.
Okay.
You cough, it goes out, and then it drops down probably within seconds or less than a minute. Whereas I'm just saying, I'm speculating, wondering, could it be with this variant that it is perhaps a bit more airborne and floating a bit more, like the person who asked. I have no idea how I got it. I'm very careful. I've talked to many people like that. And it makes you wonder. And there have been, these sort of occasional reports that SARS-CoV-2 may be a bit more airborne than we have generally discussed. So
I thought it always was airborne.
yeah, well, this is getting into semantics. So
Okay.
Droplet spread, it is going through the air, but
Okay.
in medicine, when we say airborne, we're talking about something that will hang in the air and persist there for minutes, half hour, hours.
And the person's gone. Okay. I
Yeah,
understand.
yeah.
So someone said, should I be concerned about the viral load persisting in the air when I'm outside?
No, I
Okay.
think that outside is great. I ride my bike across Manhattan every day and don't wear a mask. As I start walking towards Penn Station after I drop my city bike, I put my mask on. If you're outside and it's tight, like if you, let's say, New Year's Eve, the ball dropping, and you were in that. Of course, I saw the pictures. Nobody was wearing masks to me, the ones I saw. But if I had been there, I wouldn't have been there. But if I had been, I'd have been sure to have a mask on. If you're in tight quarters outside, somebody could cough right on you. So, but if you're just like walking down a street that's the usual New York street, I don't wear a mask out there. And I think the air is moving, it's blowing, and I think that's okay. I do see a lot of masks out on the street in New York, and I think that's fine. This is getting also into sort of the psychology and the wear and tear of 2 years of COVID. We all have risk tolerance levels, and they may change over time. So we got to find our comfort zone. My wife is different than I in terms of what she can tolerate and would want to tolerate. We're all different, my relatives. So you got to find, what works for you.
I was playing tennis indoors, and it's very, big tent. And a doctor friend of mine said, it's fine. It's a big tent, there's a lot of air.
Yeah.
You're 78 feet away.
I think so.
This is a question that came out of, I don't really, but can you predict when it'll be safe for healthcare workers now living in South Africa to return to the United States to care for their patients here?
Oh, well, I think they could do that right away. They would just have to follow the protocols for international travel. Get
Okay.
tested on their way out, get tested on, after arrival here, and I may be missing something on the question. If they mean, is it safe here? I would took it as, because we've been thinking South Africa is where this has been. Probably we have maybe more of a problem here than there now. So maybe they're saying, when would it be safe for them to come back here? And, February, maybe, if what happens, if what you said is really going to happen, things should start going down by the end of the month, and it'll get safer over time. But yeah, I think you could come now and just follow the protocols.
Okay, so someone wrote this question twice. I'm confused about the antibodies test. Can you clarify?
Sure. The commercial antibody tests that your doctor might order for you from Quest or LabCorp are not approved by FDA, nor are they recommended by either FDA or CDC to check yourself if you responded to your vaccine. They're not intended for that. They're not recommended for that use. Now, that's it. End of statement. However, having said that, a lot of doctors are doing it because it does provide something, and people, in some ways, I think patients may be demanding it, and doctors sometimes give in to their patients' demands, but really, I don't recommend doing it. I don't do it. And they're not intended for that use. They're not quantitative. We don't really know what they mean in terms of protection. But having said that, it is being done by, I think quite a bit, frankly.
So have you changed your habits since the new variant? You said you're up for mask, yeah. So are you? So before this, did you do indoor dining?
No, we didn't. We went once at the end of Delta before Omicron started, and or maybe a couple times we had gone back to it, and we felt very comfortable at one place and then not so comfortable at another that was more crowded. We left early. But then, of course, with Omicron, we stopped totally. And we had stopped through, the higher New York parts of Delta. We did order takeout. I wear the N95 on the train now. We never did start going back to shows or anything like that. Some of this is my wife's risk tolerance is more stringent than mine, but probably these are the
Well, I did go to shows before this variant, and people were so thrilled to be there. I think a friend of mine said they could have read the telephone book. It didn't matter.
Yeah.
But now you have shows like David Byrne has a show, and he only could have like 5 cast members, so he just did an improvised concert.
Oh, wow.
People are happy, but To Kill a Mockingbird just announced they're stopping in a week, and then we'll be back till June.
When these waves get bad, David, one way to think of it is what we should do and shouldn't do. I frame it as, is it essential? And you would tend to do what's essential and find a safest way possible to do it. The risk may not be zero, but it could be very low if all reasonable precautions are taken. So you could argue, I think, for mental health that some of these things, like some meetings or art, or Broadway, might be essential for some people. And if there's a reasonably safe way to do it, if everybody has to be vaccinated and masked, and I can see that. But you see what's happening with Omicron, the casts are getting it. So they, it's a problem there.
Yeah, but they're not wearing masks. But I mean, I used to go to a lot of museums, and now I'm thinking, well, you do have to be vaccinated. You have to make a reservation. You do have to show and they also check your license to make sure it's really you.
Yeah.
So I think that's it's relatively safe. Comparatively, and you can stay in your apartment 24/7. But like one of my friends said, my only social interactions is going to the grocery store. is going to the drugstore, and he said, I got to do something else.
Yeah.
You know? And I think it's just tougher in the winter. I mean, you can't walk outdoors as much. You can't really go swimming. You can't play tennis outdoors. So I think it's just, people are more limited.
I agree.
So
yeah, and this is part of what's happening to all of society. Fatigue, the durability, you can't isolate forever. It's so hard. And I think we all get that. And what I would say is we're not going to get over this soon. So we have to find a way that works for us. Each of us, a level that works with some risk, but not high risk. We're vaccinated. If we do get it, it may not be horrible. We're going to come to some terms with this, because we have to live our lives and get on with things to some extent. We're not going to be able to do everything, but we can maybe pick and choose. So I think there'll be some middle ground to find that's reasonably safe. The risk is never going to be zero, but it can be quite small. And we have the vaccines to, sort of back us up if we do, for whatever reason, if we do get it. So yeah, that's kind of how I'm thinking about it, is we may have a couple more years, 3 or 4 more waves before we get maybe the world immune. And that really depends on, can WHO and major countries like ours. I think really what we need is sort of like a Peace Corps or PEPFAR approach, where we ante up and provide leadership. I just am not seeing WHO getting all the traction they want, because it's not just giving the products, the vaccines. If they don't have the freezers, that's an issue. And then if they don't have the distribution systems, that's a problem. And we may have to really come up with something that will get us over the hump, because we're kind of stuck, I think, with these 4%, 7% vaccination rates in Africa and elsewhere. And yes, that is a concern, and especially regions maybe where there are people that are immunocompromised. That's where the virus can persist for months and have lots of chances to accumulate mutations. There's speculation that Omicron may have come from somebody with a weakened immune system who harbored the virus for months, and then it changed enough that it could start spreading. So we've got to try to shut down. Every person around the world who gets infected is a variant producing factory. And we got to shut down the factories to help us get control of this. We'll never get rid of it completely. COVID-19 is not a candidate for eradication like smallpox, because there are animal hosts. The deer in Colorado, the deer in New Jersey are infected with SARS-CoV-2. Pets can get infected. So this is going to be with us, and we have to develop our personal systems of survival and our planetary system of survival.
So I have some grandchildren, and they're all under the age of 5, so they can't get vaccines. When do you think they'll be?
That's on my wish list for 2022, that we give flu shots to everybody 6 months and over. So the 6-month to 4-year-old group, including all 3 of my grandchildren, are not eligible. They have studied it, and they didn't get a good response. The dose they chose was probably too low in the Pfizer study. So they've had to go back to the drawing board. They're going to give a 3rd dose. Another option would be to give a higher dose. So adults for Pfizer get 30 micrograms. And I think they gave these kids 3 or something like that, very low.
Yeah. But a 4-year-old is closer to a 5-year-old than a 6-month-old is closer to a 5-year-old.
Yeah, of course. Of course, but you draw the line. You have to have some categorization, and it doesn't always make sense. But yeah, in general we don't do weight-based dosing with these things, because you need, public health has to be simple, easy peasy lemon squeezy, because you go in and give it to 8 billion humans who inhabit the planet. So it's got to be very simple. And so you don't want to get into complicated algorithms based on weight. So a few age categories is generally what's done.
Okay, so
maybe 2022 is my hope. First half 2022. They're moving fast, trying to rectify this dosing problem.
So I'll let you sum up with a few words about what you would like to say?
Yeah, I would like to say something, and it's kind of at 2022, what I'd like to see. I told you what my biggest challenge is, my biggest concern is that, that we get a variant that would be worse in multiple ways. At least with Omicron, it's not more severe. I think the biggest challenges of 2022, and I'll list them and then maybe make a couple comments. Number one, hesitancy. WHO identified this as one of the top 10 threats to global health, vaccine hesitancy. Number two, global vaccination, getting the whole world immune. Number three, Omicron specific vaccines for 2022. I'm hopeful that maybe they will make a difference. The other specific variant vaccines didn't seem to be much of an improvement, but maybe it'll be for this one with so many spike mutations. The rollout and use of the oral medications, David, I think is going to be a big part of 2022. We have to increase the supply and figure out the most bang for the buck way to use them and the right people using them. Vaccines for 6 month to 4-year-old for your grandkids, I had on my list. And I think and hope that'll happen, maybe not in the first quarter, but the first half.
Okay.
4th dose boosters. And then, I think we're going to learn about, and then I think unfortunately, we're going to have 1 or 2 waves in 2022 beyond where we are now.
Well, I'm not sure if you cheered me up or not, but anyway, I want to thank you for being here and explaining very clearly and answering the many questions people had. We're very grateful, and we hope you'll come back again in a few months and update us.
Well, I would consider that an honor. I've been so impressed with the science writers in New York. When I came here, I was told it's the media capital of the world. You'll have lots of opportunities to interact with media, and I view these as educational opportunities and all of you as educators. So thanks for what all of you do. The whole world is reading what's in WAPO and New York Times and other major publications to get their information. And so it's a critical role. Thank you for what you do.
Oh, well, thank you for what thank you for everything you do. It's so it's amazing. So I'm amazingly grateful we even have vaccines. So
such a great thing. Absolutely. Imagine where we'd be without them. Yeah.
All right. So I want to say good night, everybody. Stay safe. Get vaccinated. Get your booster shots. And next week we'll be discussing, next Thursday, the 20th. We'll be discussing with Columbia University psychologists the mental aspects of COVID-19 and how to help teenagers and young adults and children and also parents not to go crazy. So thank you so much, and we'll see you next week. And Dr. Mulligan, a pleasure to spend time with you. Okay. Good evening, everybody.
You're welcome. Thank you. And thanks, everybody.
Okay. Good night.